Hello, everyone. Thank you for joining us today for the second session in the COVID-19 The Way Forward webinar series hosted by Weber Shandwick. We're delighted that so many of you could join us from all over the world. I see that a number of you are listening from Europe and from the UAE and South Africa and China, Singapore and Colombia. So welcome, everyone. I'm Jack Leslie, chairman of Weber Shandwick and the host and moderator for the series, which is designed to help you and your organizations navigate the challenges and dynamics at play in the vaccine phase of the pandemic. Now, if you're joining us for the first time, you may know that Weber Shandwick is a leading global communications and engagement firm with a presence in 70 cities and a network extending to 124 cities around the world. As our clients take on the unprecedented business and communications challenges brought about by COVID-19, our global team of experts is offering support and counsel on communicating through the crises. And that's why we're here today, to continue the conversation, to ask questions, and ultimately to better understand the issues around global access to vaccines that impact countries and economies and businesses around the world. So I'm thrilled today to introduce our experts, two global health visionaries who have decades of experience in scaling up responses to health crises and addressing health inequities around the world. First, public health expert Dr. Krishna Udakumar, who is the founding director of the Duke Global Health Innovation Center and the executive director of Innovations in Healthcare, a nonprofit co-founded by Duke, McKinsey, and the World Economic Forum. He and his colleagues at the Duke Global Health Institute are informing the global pandemic response by tracking worldwide production, purchasing agreements, and distribution of vaccines with a platform called the Launch and Scale Speedometer, advising decision makers such as the World Health Organization on controlling the spread of the virus, allocating healthcare resources, and mitigating disparities in care. We're also joined by Dr. Wafa El-Sadr, a renowned epidemiologist and founding director of ICAP at Columbia University. ICAP is a public health entity that's known for tackling some of the world's toughest health challenges. And under her direction, ICAP became a leader in responding to the HIV crisis in some of the world's most resource-challenged countries, and has subsequently expanded the focus on tuberculosis, malaria, maternal and child health, and now, of course, COVID-19. Dr. El-Sadr is also the director of the School of the Global Health Initiative at Columbia's Mailman School of Public Health, and was recently appointed the next director of Columbia World Projects. Now, before we get started, I just want to take a moment to remind everyone that you can submit questions for Dr. Udakumar or Dr. El-Sadr in the chat, and we'll have about 15 or 20 minutes at the end here to take your questions. So let's start with you, Wafa. You know, we're going to spend most of this webinar, talking about the global scene, but I thought it might be useful to start here in the States first. You've been on the forefront, as I mentioned, of so many global health challenges. But the work with ICAP and the pioneering approach you've taken there was really inspired by the experience you had working in Harlem in the early stage of the HIV/AIDS pandemic. And there, of course, you witnessed incredible impact from health inequities. So perhaps you can start off our conversation by sharing your perspective on the COVID-19 rollout here in the US and what inequities are being exposed.
Well, thank you very much, Jack, for this opportunity. And it's a great pleasure to be here with all of you and with Krishna as well. I think in many ways, my background, as you mentioned, I've been involved in issues related to public health for many decades. And it was no surprise to see how COVID-19, in a way, would shine a light again on the inequities that exist in all societies in the United States, as well as all over the world, affecting the most vulnerable amongst these societies. So from day one, it was noted in the US, for example, that certainly the attack rate, meaning the numbers of cases, the case rates in a place like New York City, for example, which are a microcosm of the world in some ways, that the case rates in New York City were much higher amongst individuals from Hispanic or Latinx background. And another inequity that was noted was the severity of disease, meaning the hospitalization rates and the death rates from COVID-19 were substantially higher amongst the Black African Americans and Hispanics. And at the same time, we also know that on the global platform, because of the difficulties that the most vulnerable groups face, particularly when lockdowns are put in place or stay-at-home orders, often it's the people who don't have the luxury of being able to work virtually, who have to go out into the community to survive, that they also have been most severely impacted by the direct as well as the indirect impacts of COVID-19. So I think it was no surprise, but again, it reiterated some of the and highlighted many of the inequities that exist in our societies that are longstanding and that need to be addressed at a very fundamental basis.
Yeah, and we've all read as far as the rollout of the vaccine, whether it's here in New York or in other places in the States, some of those most vulnerable populations are not among the first to get the vaccine. If you don't have transportation or you don't have access to a computer to make an appointment, you might get left out. And so I presume you're finding that particularly here in New York.
Yeah, and that the same issue that we saw in terms of access to services, access to testing, now we're seeing it in terms of vaccines. For example, when you look at the data in New York City and in the US overall, there's again a larger proportion of white population has been vaccinated compared to Latino and Black African Americans when you look at their representation in the population overall. And there are different reasons for this. I think one are the logistical difficulties that you were talking about in terms of being able to make an appointment online, to be persistent and nimble in terms of using computers and websites, as well as, of course, the ability to actually go to a vaccination site often outside your neighborhood also did not make it easy. So those are logistical difficulties. There also are another aspect of access to vaccination that I'd like to highlight, which is the level of vaccine confidence, or what some people call vaccine hesitancy. It's often been noted that amongst disenfranchised populations, there often are maybe a lack of information or misinformation about vaccines overall, and these vaccines in particular, as well as also a totally justifiable mistrust of research because of past abuses in research amongst the 4 populations that I mentioned in this country. So I think another aspect of our work needs to be how do we overcome some of this hesitancy? How do we engage the communities? How do we recruit champions from within these same communities that are trusted, that can then be the conduit to the community members in terms of the correct information, and try to really provide a narrative that will encourage them to get vaccinated.
Right. And of course, these inequities here we're seen on a global basis as well. And so, Krishna, I guess it's fair to say that this vaccination campaign of this size and this urgency has never really been attempted before. Your center at Duke has a tracking mechanism that I mentioned in your introduction that's really become, I think, the go-to site for people who are interested in the most up-to-date data on worldwide access and distribution of the vaccine. Can you show us how this is playing out around the world and give us a sense of what the data says?
Sure. Good morning, good afternoon, and good evening, everyone. And first, pleasure to join you and Wafa in this discussion. I'm going to show you just a couple of graphics to point out where we are. First, let's talk about, in terms of access to vaccines, who's actually been able to purchase vaccines. And we've been tracking now for the last 6 months or so what's actually happened. And over 8 billion doses of vaccine have already been purchased. And most of those purchases happened before we had any vaccines actually approved from any regulator in the world. And what you see here is how that breaks down by income category around the world. And not surprising, but still should be a cause of concern, is what you see on the left-hand side here, is that high-income countries which have about 16% of the world's population, have bought about 60% of all vaccine doses that are spoken for so far. On the other end, if you look at low-income countries, it's a little under 1 billion people represented there, and direct purchases of 670 million doses. This is largely through the African Union and the Africa CDC. And then on the right-hand side, you see Kovacs, which is the global multilateral platform that was set up to try to attempt to create a more equitable system. And our tracking would show that it's been able to procure about 1.1 billion doses. They have aspirations to get about 2 billion doses out by the end of 2021. So that's what's happening on the high-income country side versus the low-income country. What I also want to point out is what's happening in the middle here. The middle-income countries are largely getting squeezed by both sides because they're not, for the most part, eligible for aid. So they're having to mobilize their own domestic financing. And at the same time, they're often at the back of the line when they're competing head-to-head with high-income countries. So if you look at the bar that shows upper and middle-income countries, these are countries in Latin America like Mexico, Argentina, Brazil, Peru, in Southeast Asia like Indonesia, Malaysia, also includes countries like Russia, South Africa, China, Kazakhstan, almost 4 billion people represented there. Almost 3 billion people represented in about 1.2 billion doses. The lower middle income countries, so these are countries in South Asia like India, Pakistan, Sri Lanka, in sub-Saharan Africa like Nigeria, Kenya, Tanzania, Ghana, Egypt, in Southeast Asia like the Philippines, also almost 3 billion people in that category, and less than 600 million doses of vaccines that they've been able to access. So we're seeing squeezes on all sides here in terms of equitable access to vaccines. What the next slide shows here is really at a country level. So if we go beyond these income categories, how many doses have countries been able to buy? And this is color coded by the amount of their population they'd be able to cover. And you'll see the green, Canada has been pointed out through our data and otherwise as a country that's been able to purchase enough vaccines to cover everyone in the country 4 times over, at least. So you'll see countries on high income here largely that are covered in terms of being able to eventually get enough vaccines to cover their population. And you'll see low and middle income countries, the global south, that's far from where they need to be in terms of access to vaccines. And the last data point I'll bring in is what's actually happening. So we have more than 200 million doses of vaccines that have been administered in now almost 100 countries. What that leaves out are most low and middle income countries, as the map on the left shows, and you'll see the pure numbers on the right-hand side. So over 130 countries at this point that have not been able to administer a single dose of vaccine. We had a great milestone yesterday where the first deliveries from Kovacs went out 600,000 doses to Ghana. So that's a great milestone, but we have really far to go in terms of being able to get vaccines out to everybody in the world that needs them, especially in an equitable way.
Yeah, talk to us a little bit more about the pre-purchase agreements, because these are somewhat unique in that countries like the United States went in very early in the research process and actually subsidized that in a way through, well, in often ways through pre-purchase. What's that going to mean well, first of all, what does it mean to how equitably we can distribute vaccines now and over the short term? And what does it mean to the future development of vaccines? Krishna?
Yeah, I'd say it's not all negative in terms of the purchases that we've seen. So as you pointed out, we were making bets 6-9 months ago when we had no idea which vaccine might work or even if we would end up as quickly as we have with effective vaccines. So first, we should celebrate the science that in less than a year has led to the development of more than a handful now of vaccines using multiple platforms that are effective, especially effective at preventing severe disease, hospitalizations, and deaths. The amount of capital that came in from public and private sources, tens of billions of dollars, very early allowed investments to be made by both the public and private sector to go at risk in R&D. We saw hundreds of candidates enter different phases of research and development. We saw acceleration where vaccine development that previously had taken 4 to 7 years were combined into months instead of years. We saw the ramping up of manufacturing capacity at risk that allowed vaccines to become available much earlier than possible. So all of those are good things that came about by investments, both in R&D, but also advanced purchases that were made largely by high-income countries early in this pandemic. At the same time, what that means is now that we do have vaccines available, the countries that weren't able to put that money in up front are largely getting pushed to the back of the line in terms of access for their own populations.
Yeah. Wafa, Krishna mentioned Kovacs, which of course is the mechanism by which we're going to get vaccines to lower income countries. And he mentioned it just yesterday. I guess we had the first shipment to Ghana. What can you talk to us a little bit about Kovacs, how it works, and how effective you think it can be in getting vaccines as quickly as possible to lower income countries?
Yeah, I can start by, and certainly Krishna can add to that as well. The COVAX initiative is a partnership, really. It's between Gavi, which has been the entity that's been, the organization that's been spearheading a lot of the vaccination efforts in low-middle income countries. And these are the traditional vaccinations, childhood vaccinations and other vaccinations, helping secure for low-middle income countries, particularly low-income countries, and helping them in actually establishing successful vaccination programs. And also with the WHO and with CEPI, another entity that's been also engaged in vaccine research and development. So it's really great to see these three groups coming together to try to solve this challenge that Krishna mentioned in terms of the inequity in distribution of vaccines. And what it's been doing is really working hard to purchase and procure vaccines for these countries. But nonetheless, I think it's totally dependent, of course, on the amount of funding that COVAX receives from wealthy countries around the world. And we heard encouraging news last week, a commitment from the G7, as well as including the United States, to invest and fund COVAX at the level of multi-billion dollars to be able to do that. I think the concern people have is that of course the need for further investment by wealthy countries into COVAX, and as well that the current COVAX goals are very modest in terms of coverage with vaccines in these countries. And we know that we need to achieve pretty high coverage, meaning uptake of these vaccines, in order to achieve what we call population or herd immunity in these populations. And COVAX's ambitions are modest at present in terms of coverage in those countries. So I think there's a long way to go, and the need to continue to lobby very hard, advocate hard for more funding for COVAX, but also to advocate for COVAX to be more ambitious in terms of its goals. Right. And lastly, I always want to remind everybody is that getting the vaccines is very critical first step. But it doesn't do any good to get the vaccine in country and the vaccine sits in a storage facility or in freezers or refrigerators. What really is also an important challenge is how to get the vaccines to the people who need to be vaccinated. And based on my global experience through ICAP, this is not simple. Putting in place an effective, nimble, and vaccination program requires a lot of planning, a lot of resources, and commitment by countries who have sometimes fragile health systems. And we've seen the hiccups that wealthy countries like the United States have faced in our own vaccination distribution and implementation. So I think there needs to be equal attention to vaccination programs and funding those and providing the resources for those, as well as the resources to secure the vaccines themselves.
Yeah, Krishna, let's take up Wafa's point on what the goals of COVAX are and whether or not, first, those are reasonable goals, and secondly, whether they really address the pandemic correctly. I think you referenced the goal of COVAX, as I understand it, is it's about 2 billion doses by the end of this year, covering about 20% of the population of those countries that are participating. What's your sense as to, first, whether we'll meet that goal? We started, as you noted, last night, but will we meet the goal, and is that nearly enough, fast enough?
Yeah, first, I think Wafa is exactly right in the way she described Kovacs and the role that it is playing and could play. I would say simply that Kovacs is necessary but not sufficient for successful global response. If you look at the aspirations that were laid out when different stakeholders came together to create it just about a year ago, it's struggled. Everything from getting access to financing to governance and decision making and access to vaccines. On the other side, if you compare what the world would have looked like without Kovacs, it has already served a critical function, and we would be in a position much worse were it not for Kovacs so far. I do think that they will get close to 2 billion doses secured and distributed by the end of the calendar year. But that gets us something close to 20% population coverage in the countries that are eligible for coverage through Kovacs. And as Wafa pointed out, that's not going to get us anywhere near herd immunity, which is why we're now seeing even low-income countries across the African continent start to procure their resources and procure vaccines directly. The 670 million doses from the AU and the FCC is a good example of that. This is not competing with Kovacs. Even if Kovacs is wildly successful, there are still going to need to be additional mechanisms in place to make sure that populations get something close to herd immunity coverage.
All right. Let's talk about, and maybe Krishna, you can start, but Wafa, I'd like to hear from you on this because there are also people talking about perhaps changes to IP, intellectual property, allowing countries to, particularly middle-income countries, countries like India, which are quite adept at making vaccines, to ramp up production using intellectual property that may rest elsewhere. Do you have a point of view on that? Is there an emerging point of view in global health community on what we do about IP?
Yeah, IP is a really critical issue here. One, in the sense that lots of intellectual property has been created and is required for these new vaccines, but also in the diagnostics and the therapeutic space, which are also important to the global response. We've seen countries led by India and South Africa go to the World Trade Organization requesting a waiver of global IP rights to enable more urgent response and sharing of technology. On the other hand, I think there are perspectives that we would reduce the long-term incentive structure of creating new IP were that to take place. And also that just a waiver of IP, even if it were to happen, wouldn't be necessary because we're talking about really complex procedures and processes and developing new vaccines, especially on new platforms like mRNA. So it's not as if I can just give you a blueprint and you can go out and build a vaccine manufacturing plant without other support. So what I like is what Dr. Ngozi Okonjo-Iweala, the new Director General of the World Trade Organization, has really put forward, which she's been calling the third way, which is not a full waiver on IP, but at the same time creating the incentive structure and the processes by which there is a very strong incentive for those holders of IP to share much more broadly and more urgently. There are, I think, critical learnings from prior epidemics, including HIV, where we were terribly late in making sure that people living in low and middle income countries had access to technology that would save their lives. So hopefully we've learned some of those lessons. On the positive side, we are starting to see some of this already happening. So there is significant infrastructure investments in Latin America, in countries like Mexico, Argentina, Brazil, in Southeast Asia, in Thailand specifically, in India, certainly with the Serum Institute of India, where IP has been shared by vaccine manufacturers, as well as other know-how and technology that's allowing upscaling of manufacturing in a local and regional mechanism. We do think that access to more of a networked manufacturing capacity is going to be really important to the long-term response, both to COVID, but also for future pandemic preparedness.
You know, Wafa, when Krishna mentioned HIV, you were certainly there. I remember the South African, well, I think it was pharma that sued the South African government, if I'm not mistaken, on antiretroviral
Right.
the antiretrovirals, which were so important and are now the reason we've gotten a handle on the HIV/AIDS pandemic. What did we learn? What did we learn from that in terms of IP?
Yeah, I think this is there are very important analogies and there's similarities, but there are differences. I think historically we know that if it were not for the production of generic antiretroviral treatment medications for HIV, we would be in a very different place globally in terms of the HIV response. It was the generic companies, particularly started in India and then expanded to other generic manufacturers in sub-Saharan Africa, for example, and in Brazil and so on. That was critical to be able to rapidly produce sufficient antiretroviral drugs at a low enough price to be able to actually meet the enormous demand in low and middle income countries that existed. Without that, in all honesty, millions and millions of people would have died and millions of children would have been born with HIV. So it's critically important to learn from that historic fact that needed to happen, and it needed to happen in the context of a pandemic. This is no normal times, no ordinary time. There's a pandemic ongoing, and delaying by 1 day access to vaccines to an individual or to a population is not good for anybody, including for individuals who reside in high-income countries. We are an interconnected world, and the rapidity of allowing for other manufacturers, particularly India and Brazil and South Africa, to manufacture these promptly would be very important. I'm also a strong believer in the value of sharing technology and sharing expertise and building the capacity of countries to be able to produce these vaccines, as well as also to be able to respond to some of the other health threats within those countries. I also think it's interesting that we're thinking now of sort of getting everybody 1 or 2 doses of these vaccines. But it's quite possible that we're going to need to give vaccinations maybe next year and the year after on an ongoing basis as variants are identified that may outsmart our current vaccines. So I think we have to be thinking of meeting the immediate need now, which I think Krishna addressed beautifully with the slide he showed, but also to think on the long term. We may need to be producing the new vaccines that are going to be produced against these new variants on an ongoing basis. And I think in reality, we will need to be producing such vaccines globally and in many of the contexts that I mentioned. Otherwise, we will never meet the demand, the global demand.
Right. That's a very good point. Krishna, you had mentioned in your overview middle income countries. I wanted to come back to that because I think it's so important. And many of our listeners are from countries like South Africa, and Colombia, Indonesia, major populations that aren't among the poor countries that may get Kovacs right away, but may not have themselves the financial wherewithal to vaccinate their populations. Talk to us about the challenges of those countries.
Yeah, so the middle income countries are facing threats on all sides here. They generally don't have fully mature health systems, so there continue to be vulnerabilities in place. At the same time, they aren't getting either the subsidized price points or the donor-funded vaccines as quickly as low-income countries are. So we're seeing this struggle where they're becoming more desperate over time. So take South Africa, for example. They struck a deal with AstraZeneca initially for access to that vaccine directly, and ended up paying more than twice per dose than what the European Union did. And that just seems absurd on its surface, that given the income levels of those two countries, that South Africa would be the one paying more. But that's what you have to do when you're desperate and you don't have other mechanisms. And it turns out, because of the variants, as Wafa mentioned, they decided that wouldn't be an appropriate vaccine to go with, and became the first country to roll out the Johnson & Johnson vaccine at any scale. At the same time, we've also seen Mexico, for example, that for months was trying to secure earlier access to vaccines in the midst of a terrible burden of disease there. and eventually ended up getting access to vaccines from Russia. And so what we're seeing as middle-income countries especially become more desperate and not moving to the front of the line on some of the vaccines that have been approved by the US FDA or other stringent regulatory authorities, is that they are now also trying to source vaccines directly from other places.
I promised that we would come to questions, and I'm getting a few up here on my screen, and I'm reminded when I look at these questions that about a third or so of our revenue is in the healthcare area. So we have quite a few hundreds and hundreds of folks who do nothing but healthcare on our staff, and many of them are listening in. So the first question is an interesting one, and Wafa, maybe we'll go to you first, and that is, are there positive outcomes from the vaccine in terms of building infrastructure, supply chains, and so forth to support health in low-income countries that may go beyond the pandemic? Are the investments going to pay off in other health issues like cancer and diabetes? And what's happening to the state of our health systems as a result of this pandemic that you see?
Yeah, I do think, I'd like to kind of step and again call on HIV as an example. Is that I think, for example, the investments by the U.S. through the President's Emergency Plan for AIDS Relief, PEPFAR, and the Global Fund in building the infrastructure for scaling up of HIV programs has yielded enormous benefits in terms of these same countries being able to tackle other challenges. These countries, the countries that have seen an investment in one area, are doing much better in terms of addressing other challenges. So I think there's definitely the history of these investments often lead to spillover effects, or what I call spillover effects, in other areas. I do think that, for example, I believe that with appropriate resources, particularly in low middle income countries that have been building that infrastructure for HIV, that we can layer the vaccination programs on utilizing the systems, then the surveillance systems, the distribution system, the procurement systems, the forecasting systems that have been put in place for HIV treatment and prevention. I also think that another dimension that I think is quite relevant is the effort to vaccinate for COVID-19 is really the first major effort for adult vaccination on the global platform. Most of experience around the world has been focused on childhood vaccinations, and many countries have done a really great job in terms of achieving high coverage with childhood vaccines. Many countries around the world, there are no adult vaccination programs at all. And even in our own country here in the United States, we've done modestly well in terms of adult vaccines, whether you look at the annual influenza vaccine or the pneumococcal vaccine or the shingles vaccine. So this experience in scaling up an adult vaccination program can bode well for potentially, again, putting in place adult vaccination programs for other conditions as well that are very important, particularly with an aging societies and so on, where adult vaccinations need to be an integral part of a health delivery system.
Yeah, you know, your point on how HIV built up health systems in Africa. I chair EGPAF, the Elizabeth Glaser Pediatric AIDS Foundation's board, which operates just in Africa. And at the outbreak of this pandemic, we actually didn't see in many African countries the level of infection that we thought we might. And not that this was the entire reason, I think it's also the younger population, but there were very robust, because of PEPFAR and HIV, very robust systems of testing. And many of them pivoted to COVID during this time. But there's also, both Wafa and Krishna, you can comment on this. There's the flip side of it, which is that all the progress that we've made in HIV and tuberculosis and malaria and so forth has had somewhat of a setback. Isn't that right? In many of these low-income countries, because people are not getting to clinics. They're not getting tested as much as they were before. Can you talk to us a little bit about some of the setbacks in other diseases because of the COVID pandemic? Wafa, why don't you start?
I can start. I think there have been several surveys that have been done, some by the WHO and others, looking at kind of what are the potential dire consequences of COVID in terms of setbacks in reproductive health, and HIV, TB, malaria, and access to medications, chronic medications for people with high blood pressure and so on and so forth. So I think that's a great concern. I do know, though, based on our experience at ICAP, is what has been heartening to see is how, because of the restrictions that COVID imposed on health delivery, for example, lockdown, inability to travel to a clinic, people being afraid of going to health facilities, being afraid of catching SARS-CoV-2 at health facilities, and lockdowns that you can't, and curfews, that has limited access to health facilities. But at the same time, what we have observed is just a remarkable innovations that have appeared right and left in many of these countries of programs and ministries of health that have really used the opportunity to rapidly pivot and go into new models of care. For example, for HIV, a chronic disease, they moved rapidly to what's called multi-month dispensing of medications. So now the 6-month dispensing of medication is given rather than every month, so people don't have to come to the health facility. There have also been community distribution of medications and doing testing in community in a safe manner in community settings. So it's been, while there have been, of course, great difficulties because of COVID, there's been this burgeoning of innovations that's really been remarkable. And we've been looking at some of the HIV-related data at ICAP. And while we did see an initial decrease in terms of testing and new ART initiations, antiretroviral drug initiations, and so on, like right after the lockdowns, what we saw in the latter 2 quarters is a rebound. And it's really fantastic to see that it demonstrates the resiliency of these of the health systems.
Right. Well, that's good news. Krishna, let me. I'm going to take another question here, which is a good one. How can countries handle vaccination for immigrants or refugees who may be particularly vulnerable? You know, refugees won't show up in one of your bars as a country because they're stateless. Are you seeing any promising signs in that on that horizon? Do you track that?
We've been looking at refugee health in several ways. One of them really is, how do you create the policy environment and the data systems to be able to actually track more effectively? And what we've seen, for example, by studying national and regional health policies in East Africa and West Africa, is that the national health policies often don't allow for sharing of or connections of information systems, so that when we see cross-border migration, especially, we tend to lose essential data. And so even making sure that kids are vaccinated, whether they're on one side of a border or the other, making sure that people continue to get access to essential health services is becoming more and more important. So some of the work that we're focused on is really trying to strengthen policies at a national and regional level to allow for more appropriate and responsible data sharing. So let's make sure we have the right governance, security, and privacy systems in place. But with that confidence, let's make sure that we're opening up the value of the data. And I do think that's going to be hopefully one of the things that comes out of not just this pandemic, but the post-pandemic planning, is really the value of data and disaggregating the data. So looking at country level income categories, like I started by doing, is important, but by no means does it give you truly localized, actionable information. So we really have to be better. And we've seen this at the state level in the US, where different states are at very different levels of being able to track demographics, of being able to understand if their own distribution of vaccinations have been done equitably or not. So data systems need to be much more robust and more disaggregated for us to be able to address challenges like this. And maybe just picking up on Wafa's last point, I really want to emphasize, I think this is a window of opportunity for us to help define not just in low and middle income countries, but everywhere in the world, what a post-pandemic health system should look like. Even in the US and other high income countries, we saw a year ago the shift from brick and mortar care to virtual care, digital health solutions at a pace that hasn't happened in decades. And we saw quickly the regulatory regime take over and try to create some at least short-term flexibility. So the next set of planning, as we're getting through vaccination, as we're thinking about reopening, really needs to be, what are the lessons we want to learn so that we're defining what our future health systems really look like?
Yeah. There's another good question on here, and Wafa, maybe you can take this. In addition to all the global health challenges that we've seen headlines about silent pandemics like mental health and domestic violence. How do we tackle that? And what have you seen in the places you work?
Yeah, I think, as I touched on this when I talked about the indirect effects of COVID, is that there are the very direct effects in terms of the illness itself and its complications, but there are enormous indirect effects, and those include mental health, particularly depression, anxiety. They include as well an increase in domestic violence, both against children and against an intimate partner. Violence have also been noted across the globe. And there are lots of different reasons for this. Obviously, for the mental health, we can imagine the situation that people are existing in, from lockdowns to loss of income to isolation. All of them lead to mental health distress, as well as, of course, on the other hand, in terms of the domestic violence, because of the stresses of this pandemic and economic and otherwise. And what we have been doing in several places where we've worked is to, first of all, we've been very involved in doing surveys to measure these impacts, and that's been important. Like, for example, we're doing a survey now amongst older individuals, 70 years and older, in New York City, who are not residing in nursing homes or reside in the community, to really measure the impact on their own beliefs and health and so on, including looking at mental health, so that we can actually define interventions to tackle depression, anxiety. At the same time, there's been also a lot of motivation and information and communications about these indirect effects around the world, so that we also are informing people of the risks of domestic violence and what they should do, and providing them with the resources and to be able to access support systems in their communities as need be. So I think these are, some of these effects are going to be quite long-standing and durable, and sadly beyond the impact of the epidemic in and of itself. So we should be thinking about the immediate response as well as the longer-term responses.
Exactly. I wanted to shift topics a little bit. Last week, we had a conversation, I guess now that I think of it, with a colleague of each of yours, Dr. Ho, who's a colleague of yours, Dr. Al-Sadr at Columbia, and Dr. Mike Merson, a colleague of yours, Krishna at Duke. And we talked that was really devoted to variants. By the way, just as a little plug, we made news in that webinar on the variants that Dr. Ho found in New York that were the subject of an article this morning in the New York Times. So the Times was a week late with the story. But the issue, of course, is that, and this is something where I'm concerned in the business of communications and messaging, that we might be getting the messaging a little wrong on dealing with inequities in global access, and that we oftentimes put it at a moral level or an ethical level and not at a self-interest level. The vaccines the viruses act in a very self-interested way. They mutate to stay alive. And it's not wrong necessarily for countries to act in a self-interested way if they understand, the United States, for example, that if we allow this virus to run amok in countries because we have not vaccinated there, that there's going to be more and more mutation, which will just come back and haunt us at a later date. Talk to us a little bit about this factor. are we likely to see, because we are slower in getting vaccines out to low-income countries, more mutation happening that's going to require us, Wafa, you mentioned it earlier, perhaps to have annual vaccination. Is that the likely outcome in your mind? Wafa, we'll start with you.
Well, I think it could be the outcome for, and that's the reason why you mentioned the word self-interest. I mean, I think it's in everyone's interest to stop transmission of this virus everywhere, because it is through transmission and replication, multiplication of the virus that these new variants arise under pressure of vaccines and under pressure of antibodies that people develop to this virus. So that makes it incumbent upon all of us to really think of ourselves truly as a global community. I always say these viruses know no borders, and that getting vaccines, as what Krishna said, to the global community is very important for our own self-interest. So it's for public health. I think it's for, I always say it's for public health, it's for equity, and it's for self-interest, all of them together, all the three of them. So we need to be mobilizing to do our very best along those three dimensions if we are to really effectively control the transmission of this virus.
Krishna, do you have thoughts on that?
Yeah, I fully agree. I think maybe getting a bit over my skis here and talking about communications when you're on the line here, Jack, but I think we've done, as a global community, a pretty poor job of communicating the real value here. We shouldn't go away from the ethical, moral, and humanitarian urge here because that's appropriate to talk about. But in addition, there's a health imperative that we can save more lives around the world by far if we're more equitable in our early distribution of vaccines. And for self-interest, both for our own health as well as for economic productivity, every model that's out there shows that we're better off to the tune of hundreds of billions of dollars, if not trillions of dollars of improved economic productivity in high-income countries if we can share vaccines more equitably now as opposed to years from now. So no matter what worldview you take, there's really the same answer. And we've done a pretty poor job so far of pulling together all of those arguments cohesively.
Well, that's a good transition, I think, into my last question, which when you talk about the trillions of dollars in productivity that we're losing, there are, listening in on this call are many of our clients who themselves are large multinationals who have a real, obviously, business stake too in how this pandemic is handled. Talk to us a little bit about what you see potentially as a role for business. What role can business play in global vaccination efforts? Maybe we start with you, Krishna, and then move to Wafa.
Yeah, we've seen, I think, a key opening where there's a significant opportunity for private sector leadership, especially in places where we've seen the strains in terms of public sector's support by the local population and community, as well as the lack of cohesiveness in their implementation. So I'd really think about private sector leadership in the space in maybe three ways. The first is trying to serve as a trusted source of information. From your own data, Jack, I've been learning about how highly people view their own employer as well as private sector leaders as trusted members of their community for information. So dealing with misinformation, making sure that we are proactively building vaccine confidence and making sure that we're spreading the message about appropriate public health measures are all really important components. The second is to step in and be complementary to the public sector in implementation. The public sector anywhere, including in the US, is not going to be able to implement vaccination at scale. So there are significant opportunities for the private sector, for business, whether you're in the health sector or not, to serve as a partner in making sure that we are distributing more efficiently as well as equitably as we go. And the third, I think, is really to take the long view, both from a business as well as employer perspective. I think we will have long memories of who did the right thing and who didn't and took the short view when we look back at what happened. And we've started to see, I think, promising stories of private sector leaders who have really stepped in and not just cut back on investments, but moved up investments that they would have made anyway to ensure that there's a private sector role for sustainability. And we're also seeing businesses step up and take a more holistic view on what their team, their employees really need, and in making flexible work arrangements and addressing mental health challenges and the like. So I think there is a real need and opportunity for business and private sector leadership here.
Yeah, Wafa, would you like to have a last word? I promised we would get you both off before 10 o'clock because you've got meetings yourself. Any last words on that issue of role of the private sector or broadly the inequities that we're facing?
I think Krishna covered beautifully all the different dimensions. I do think I found that this with this crisis now, it's brought public health and the business world much closer together. It's been really I've welcomed the opportunity to engage with leaders and individuals in the business community where I haven't had that opportunity before in my public health world, and I think it really demonstrates how everybody realizes that there really should not be a conflict between public health and economic health. Is that we can find we can find in the middle there the appropriate balance between public health and economic health. And I think there's been, as you mentioned, there've been a lot of businesses that have been able to rise to the occasion and engage with public health and have enabled their workforce to be safe and productive under very difficult circumstances, and also to be willing to engage with the public health community in terms of how to balance and make these tough decisions as they move forward. I always remember, I think this is something Krishna mentioned, the examples of businesses that in the HIV epidemic kind of again rose to the occasion and decided, for example, to provide HIV treatment, life-saving treatment to their workforce at a time when they realized they're training their workforce and they're losing them, as and that was not a good formula for success.
Right.
And I remember those firms very clearly in my mind. They focus on the health of their workforce and also extended it to the communities around in the areas where they were situated. So I think there's a great opportunity for us to prove to the world that there really should not be a conflict between public health and economic health.
Yeah. Well, that's a great way, I think, to end. I mean, I wish we had a lot more time for this conversation. It was really, really terrific when we thank you, Krishna and Wafa, for taking the time out of your busy schedules. And I think I speak for everyone when I say this was a very enlightening conversation, and we still have a lot of work to do, as you both noted, in bringing greater equity to global health. And also to our viewers from around the world, I just wanted to thank all of you for joining this second session of our COVID-19, the Path Forward webinar series. That last exchange, I think, was a great segue into what will be the topic next week for our third and final session, when we'll be talking about navigating the uncharted landscape, and we'll look at top questions that companies and corporate leaders should be asking as we get into the vaccination phase of this pandemic. We'll be releasing the specific time and date soon, so watch webershandwick.com for more details. And until next time, stay safe and stay healthy, everyone. Thanks very much.